I'm Dr. John Day. I'm consultant in infectious diseases and general medicine at Southend University Hospital. I'm passionate about clinical criteria for discharge because it's helped me to organise my thinking on ward rounds and also to communicate that thinking to colleagues. A little bit like bananas in pyjamas. Are you thinking what I'm thinking? As consultants, I think it's often the way that we're not always conscious that the thinking that's going on inside our minds isn't always being clearly communicated by colleagues. We don't get a lot of thinking time on ward rounds often, so sometimes that thinking needs to be communicated after we've walked away from the bedside as well. The clinical criteria for discharge is a way of identifying what our objectives are during a patient's stay in hospital. Ideally, this is a process that we agree with patients, where we find out from them what their expectations are of a stay in hospital. So we could think of the clinical criteria for discharge as being something that once we as senior decision makers have defined can be delegated to our junior doctors and also to members of the nursing staff as well. When we're meeting at our whiteboard every day, we include some discussion or sometimes some agreement or refinement of the clinical criteria for discharge that enables us all to synchronise our plans with each other. So for instance, if the therapists, our social workers and the nursing staff know what we are aiming to achieve, then they can be more efficient in their planning for when the patient's going to be discharged from hospital. One way to get started with clinical criteria for discharge is to start asking the question at the whiteboard round, why is this patient not ready to go home today? This is sometimes a better way of defining the obstacles to discharge than when do we think the patient will be going home. It also gives an opportunity for us to challenge one another where perhaps we've set the bar too high on certain criteria. One example would be a patient who comes in with pneumonia. When they come in, they're requiring supportive treatment that can only be given in hospital. We might set criteria that once they're no longer requiring oxygen, once their temperature has been normal for 24 hours, and perhaps once their neutrophil count is better than it was when they were admitted to hospital. We wouldn't set a criteria to say that they're fully back to normal and they're no longer symptomatic. Similarly, I wouldn't set a criteria that their CRP needs to be back to normal. We know that full recovery will take much longer, but that can take place outside of hospital. You can be the one that discharges. One of my F1s said to me the other day, am I allowed to discharge a patient? She's right to ask that question in as much she's only been qualified for less than 6 weeks. But the way I explain it to her is that I'm the one that discharges the patient, but she's the one that follows the criteria that I've set for making that decision. She's sufficiently experienced to be able to identify when a patient has met those discharge criteria and when they haven't. Similarly, we have a number of nurses on the ward who are able to interpret those criteria. And this is particularly useful at weekends. In an ideal world, all of our patients would be reviewed at least once a day by a senior decision maker, such as a consultant or registrar. At weekends, we don't have the manpower to enable that to happen in medicine. What we rely on at weekends is that a patient who has had clinical criteria for discharge set can be reviewed by a junior doctor, maybe one who's never even met the patient before, to identify whether those criteria have been met or not, and what remedial action might be necessary if they haven't. Or alternatively, a senior nurse who will be able to determine this. On the second board round of the day, it's an opportunity for us to review our progress with the clinical criteria. In particular, checking whether they've now fulfilled all of those criteria and therefore medically fit for discharge. It's also an opportunity to review whether the clinical criteria for discharge are still relevant and appropriate, perhaps in the light of new developments. It's not unusual for a patient to develop a complication during their stay in hospital, which may require revision of the clinical criteria. Let's summarise top 10 tips for clinical criteria. Firstly, it's important that we think and talk out loud, ideally with patients, perhaps with relatives as well if we have an opportunity, and with our colleagues. This is best done around the whiteboard when we have a collection of all those who are involved in the patient's care. It also provides opportunity for any member of the team to challenge or to question or to check any element of the plan. Secondly, be smart. Make sure the criteria that we set are specific, they're measurable, they're achievable, and within a realistic time frame. Thirdly, keep rehabilitation goals separate from the clinical criteria for discharge. So, for instance, often I see in notes, ready for discharge when mobilising. That's something that, of course, our therapists are expert on assessing. And these days, it's not necessary that a patient should be fully rehabilitated and fully back to their normal functional baseline by the time they leave hospital. Fourthly, review the clinical criteria for discharge progress on every whiteboard. Fifthly, learn from delays. If something has not happened in a timely fashion, that's an opportunity for addressing some of the wider underlying issues that contribute to delays in progress. Clinical criteria are also a useful method for training our junior doctors and nurses. One of the most difficult things that we have to learn as a hospital doctor is safely discharging patients. Talking through clinical criteria for discharge with colleagues is a useful way of teaching them to identify what the issues are and helping them to understand what can be achieved out of hospital, either by general practitioners or in the outpatients clinic as well. Clinical criteria for discharge can be an excellent handover tool. They're a concise method for communicating to colleagues who may never have met the patient before on what to look out for when they review the patient, giving them specific criteria to measure the patient's progress by. I like to think of CCD as a myth buster as well. There are certain things that carry on in hospital that aren't really appropriate reasons for patients staying in hospital. So, for instance, if I hear people talking about that the patient's INR needs to be back within normal range, I remind them that there are many patients who attend our anticoagulation clinic who have an INR of 6, and these are managed on an outpatient basis. They don't require admission to hospital, and therefore we shouldn't seek perfection in the patient's anticoagulant control prior to discharge. How do we record the clinical criteria for discharge? Obviously, the best place to record this is in the patient's notes. We've also been using a sticker, which helps us to identify clearly in the notes those criteria. And anyone opening up the notes, their eyes will quickly settle on those criteria. We tend to use those particularly before a weekend, especially before a long weekend. So what are the benefits of clinical criteria for our patients? Many patients stay in hospital unnecessarily. They're waiting for something to happen. This is often because there's no clear plan of what it will take for them to be able to leave hospital. When doctors document clinical criteria for discharge, then discharges will happen. One of the things that I have noticed in the years that I have been using clinical criteria for discharge is it's very rare now that I get told by a junior doctor, we didn't discharge this patient because we were waiting for you to come and review them. The reason for that is the junior doctors already know what I'm thinking and planning about that patient. without me having to come back and tell them or remind them